Good morning and welcome to day 2 of this public meeting of the Physicians Focused Payment Model Technical Advisory Committee, known as PTAC. My name is Angelo Sinopoli and I'm one of the co-chairs of PTAC along with Lauren Harden. Yesterday, we began our day with opening remarks from Dr. Liz Fowler, the CMS Deputy Administrator and CMMI Director. She provided some insight on the Innovation Center's vision to achieve the goal of having all beneficiaries in accountable care relationships by 2030. We also had several expert panelists and presenters share their various perspectives on identifying a pathway toward maximizing participation in population-based total cost of care models. Today, we have a great lineup of experts for 3 listening sessions. We have worked hard to include a variety of perspectives throughout this 2-day public meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed models. Later this afternoon, we'll have a public comment period and welcome participants either in person or via telephone to share a comment. As a reminder, public comments will be limited to 3 minutes each. If you have not registered to give an oral public comment but would like to, please email prior to the 2:40 p.m. public comment period today. Again, that's PTAC registration at norc.org. Then the committee will discuss our comments for the report to the Secretary of HHS that will issue on identifying a path toward maximizing participation in population-based total cost of care models. Because we might have some new folks online who weren't able to join yesterday, I'd like the committee members to please introduce themselves again today. Please share your name and your organization, and if you would like, you can tell us about your experience with our topic. I will cue each of you as we move around the table. I'll start. I'm Angelo Sinopoli. I'm a pulmonary critical care physician by training. I've had many years of experience in population health, network management, and enablement company development, and presently I'm the Executive Vice President for Value-Based Care at Cone Health in North Carolina. First, let's go to our PTAC members joining us by Zoom. Larry, are you there?
Yes, I am, Angelo. Thank you. I'm Dr. Larry Kaczynski. I'm a gastroenterologist by training, and I practiced for 35 years in the Chicagoland area in private practice. The last 10 years of my life has been devoted to value-based care, specifically attempting to develop solutions for specialists caring for patients with chronic disease. I am the founder of Sonar MD, a value-based care company that was launched following its successful approval by PTAC back in 2017. So I've been on this committee now for 3 years and look forward to the discussion today.
Next is Jay.
Hi, my name is Jay Feldstein. I'm trained and boarded in emergency medicine, practiced emergency medicine for 10 years, and then was in the health insurance world for 15 as a medical director and also running health plans in both the commercial in government space. And for the last 10 years, I've been the president of the Philadelphia College of Osteopathic Medicine, trying to educate our future workforce in our new world of value-based care. And anxious for today's presentations and discussions. Thank you.
So we'll go around the table now. I'll start with Jim.
Hey, good morning. My name is Jim Walton. I'm from Dallas, Texas. I'm trained in internal medicine. I practiced in Waxahachie, Texas at the beginning of my career, developing some rural health centers and helped lead a multi-specialty primary care group. I moved my practice to Dallas, Texas, leading the community health strategy for Baylor Healthcare System and was their chief health equity officer. I finished my career as an executive leader for a large IPA, primary care and specialty care IPA, and that developed an ACO engaging in APM contracts with CMS, Medicaid, commercial, and Medicare Advantage. And I currently serve as an independent healthcare consultant.
Good morning. I'm Lee Mills. I'm a family physician in Tulsa, Oklahoma. I have worked in multi-specialty medical group and health system leadership. I've practiced, operated, or helped lead 5 different CMMI models over the years and been executive leader in 2 different ACOs. and then spent 4 years as chief medical officer of a regional provider-owned health plan working in commercial individual exchange and Medicare Advantage space. Thank you.
Good morning. I'm Lindsay Botsford. I'm a practicing family physician and PCP in Houston, Texas with Amazon One Medical, where I also serve as our medical director for the Midwest and Texas. I'm currently the chair of the governing body of Iora Health Network, which is our ACO reach, ACO. That's it.
Good morning. I'm Jennifer Weiler, tenured professor at the University of Colorado School of Medicine and practicing emergency physician. I'm a co-founder of a large health systems care innovation center where we partner with digital health companies to grow and scale their solutions to improve high value care. I'm a co-developer of an alternative payment model that was evaluated and endorsed by this committee and have over 10 years of experience in group practice and delivery side hospital leadership.
Good morning, everyone. Walter Lin, founder of Generation Clinical Partners. We are a group of providers in the greater St. Louis area passionate about the care of the frail elderly living in senior living, those with serious illness and complex chronic conditions. We work with a number of different value-based programs, including specialized ACOs, institutional special needs plans, and PACE programs.
Good morning, Chini Puluru. I'm a family physician by trade, practiced for 15 years. I've spent 20 years in the value-based care space, first at Dooley Health and Care, which is a multi-physician group, multi-specialty physician group, as well as its subsidiary MSO that covered 5,000 physicians implementing value-based care platforms end-to-end at scale with industry-leading quality and financial outcomes. After that, left and was chief clinical executive at Walmart Health. Excited to be here, 4th year in PTAC, just starting.
Good morning. I'm Lauren Harden. I'm a nurse by training and Chief Integration Officer for HC2 Strategies, where we partner with communities, states, health systems on building connected communities of care for complex and underserved populations. I'm deeply involved in implementation of the Medicaid waiver in California and other states, and have a background in leading care management in NextGen, MSSP, and BPCI, designing a complex care model that is all payer, all populations, that scale to multiple states, and then was part of the team that founded the National Center for Complex Health and Social Needs and spent 10 years partnering with communities, states, health systems, payers on designing interventions and models for complex and underserved populations. Excited to be here today.
Thank you, Lauren. And we have one of our members, Dr. Josh Lau, who's unable to attend this morning, but he'll join us for the afternoon sessions. So now I'm going to turn things back over to Lauren to lead the next listening sessions. Lauren.
Thank you so much, Angela. We're really pleased to welcome 4 experts to our listening session today who will present on organizational structure, payment, and financial incentives for supporting accountable care relationships. At this time, I ask our presenters to go ahead and turn on your video if you haven't already. All 4 experts will present, and then our committee members will have plenty of time to ask questions. So begin preparing those as you hear the speakers. The full biographies of our presenters can be found on the ASPE PTAC website, along with other materials for today's meeting. So I'll briefly introduce our guests. Presenting first, we are welcoming back Dr. Alice Chen, who is the Vice Dean for Research and Associate Professor at the University of Southern California. Alice, please go ahead.
Hi, everyone. It's great to have the opportunity to talk to you again. Thanks for having me here. Next slide, please. So when thinking about how to incentivize participation in these advanced payment models, I think it's first helpful to have a lay of the land. And I want to perhaps state the obvious, which is that if you're not participating in an advanced payment model, you're more than likely going to be facing fee-for-service payment rates. So something to keep note of is over time, the relative attractiveness of fee-for-service payments have been changing. In particular, fee-for-service payments have been falling cumulatively between 2021 and 2024. There's been a 7.8% fee reduction, and there's proposed fee reductions of 2.8% in 2025. And you would think that this would incentivize participation in APMs, but at the same time, the bonus participation payments to the APMs have also been falling. They will be zero in performance year 2025. So I think we want to keep that in mind. Next slide. When looking at ACO participation, I want to focus on the MSSP program, the largest Medicare ACO program that we have. And what you can see from this graph is that over time, participation in particular since 2019 has been flat. You can see that in the green line. But it really isn't because we haven't had new entrants. It's really because the number of entrants have equated essentially the number of dropouts, which prompts the question of who is entering and why aren't people staying? Next slide. And one thing when you look at this a little bit more carefully is what you can see is each successive ACO cohort has looked a little bit different, and the ACOs that stay in the program look a little bit different than the ones that leave. In particular, because this is a voluntary program, what we've been seeing is that participation has been skewed towards ACOs with lower baseline spending. And what this graph is showing you is essentially each successive ACO cohort has started to have spending per beneficiary at a level that's lower than the regional average. And over time, the ACOs that remain in the program are those, again, with lower spending relative to their regional average. And this is problematic for two reasons. The first is that we know that ACOs with high risk adjusted spending actually lower spending more than the ACOs with originally low spending. And in addition to that, it is efficient for the high spending ACOs to participate in the program. Those are precisely the ACOs and provider groups that we want to be able to incentivize more efficient spending behavior. Next slide. So when I look at the incentives for participation, I don't want to spend too much time on what's already been done, but I definitely think that there have been large improvements, in particular since I last talked to this committee on the design of the MSSP program. New this year, they've incorporated a prior savings adjustment, which will mitigate the rebasing ratchet effects. They've added an administrative component in the benchmark growth, which will ensure that there's a wedge that is there between fee-for-service expenditures and ACO savings. And in addition to that, they've limited benchmark reductions due to the regional blending. And this last point in particular affects the incentives for ACOs with higher than regional spending to participate. So they've capped the adjustments at negative 1.5% for ACOs who have higher than regional spending. Next slide. So, as a result of the new policy changes, what we've seen now is that benchmarks are updated using what they've called a three-way blended factor, which includes the national trend, the regional trend, adjusted for some of the factors that I mentioned on the previous slide, previous savings, and they've introduced an administrative component into this. And this three-way blend makes me wonder if this is sufficient to incentivize entry and reduce dropout. It's also become quite complicated reading through all of this documentation and figuring out how benchmarks are actually being updated over time. And to offer some ideas on a roadmap for how to simplify this process and also get us to a point where we might be able to encourage more participation, I think what I would propose is that we have the initial benchmark set at ACO's own historical spending, as it is currently done, and over time have a regional convergence phase where essentially benchmarks are updated at an annually projected rate of the fee-for-service expenditures minus a savings rate, which will differ depending on the ACO spending relative to the region. And one thing I would mention here is that I would just caution that these changes in movement toward regional convergence be gradual, as we've seen the ACOs that face large benchmark changes tend to drop out at pretty high rates. Once convergence has been achieved, I think we can then move to just annual updates based on a combination of risk-adjusted regional rates with a benchmark bump or even an administrative trend. And I think you heard yesterday that the spending at the rate of inflation was proposed, and I think setting the administrative trend at the rate of inflation is certainly a possibility. But we want to take into account changes in healthcare technology, both on the services and the pharmaceutical side, which will increase spending, and that isn't going to be reflected in just inflation. Next slide. What else can be done other than looking at benchmarks? I think there are other financial levers that can be pulled here. You can make non-participation less attractive. So for example, enforcing site-neutral payments to providers that don't participate, or make participation in 340B drug pricing programs conditional on participating in an APM. On the flip side, you could also make participation in the APMs more attractive, including increasing the bonus payments for participation and increasing the shared savings rates, which really will allow providers to be able to capitalize on their investments of participating in an APM. Next slide. So I want to sort of add a little bit more nuance here in thinking about, what are the types of providers that are participating. And I want to talk a little bit about the smaller organizations. There have been, again, recent implemented changes to encourage participation among smaller low revenue ACOs, including slowing down the on-ramp to downside risk and providing some upfront capital investments. I think what we want to think about here is, can we get even smaller, more PCP-centric groups to participate? And one viable path forward is to create a track that includes only primary care spending in the risk contract, and have a contract that's based essentially on capitation. For these smaller groups, allow them to receive some participation bonus, which they're currently not doing, and consider capping their losses. And for groups with small revenues, you want to cap losses based more on their revenues than their benchmarks, which might far exceed their low revenues. Next slide. So to close out here, I offered some ideas on how to improve participation through re-examining benchmarks, through increasing financial incentives for participations, through things like bonuses and increased shared savings rates, and through creating a track for smaller PCP-centric groups. But I want to leave off with just a few quick pointers here of things just to not forget about. The first is risk adjustment. It's the same approach that's been used in the Medicare Advantage program. It suffers from gaming through coding and insufficient adjustments because it takes the status quo spending as the appropriate level of spending. I think if we increase beneficiary participation, we will see improvements in an ACO's ability to change care, and that will also make participation more attractive. And finally, when thinking about how do the incentives trickle down from the organization level to the physician level, I want to say that restructuring physician financial incentives, there's a long literature showing that it will affect physician behavior, but there are a lot of non-financial impacts here. In particular, organizational norms and behavioral economics suggest that physicians will change their behavior depending on practice norms. I have recent research showing that when physicians are forced to move from one practice to the other because the department closed and they move within less than a 10-mile radius, it turns out that their service intensity really changes from to match the new practice that they're joining. But these are just some of my thoughts. I think I'm out of time, and I look forward to a great discussion with my fellow panelists and the committee.
Thank you so much, Alice. And committee members, please be capturing your questions. I know you're going to be very interested to dive in on this session. Next, we're excited to have Mr. Michael Meng, Chief Executive Officer and co-founder at Stellar Health. Welcome, Michael. Please go ahead.
Thank you. Good morning, everyone, and appreciate you all having me here today. Next slide. Just a quick background on myself. I'm the co-founder and CEO of Stellar Health. We'll come to that in a second, but prior to that, I spent 10 years at a private equity firm investing in all sorts of different healthcare companies and physician groups. Today, I sit on the board of 3 different physician groups across the country, ranging from 10 docs in size to 50 docs in size to 150 doctors in size. I'm very proud of the fact that, too, I actually get placed on the compensation committee despite not being a physician, which I think is an honor that I have earned with these colleagues. One last thing to note too is I do sit on the board of the CUNY School of Public Health. I've always cared about not only healthcare in a business sense, but also policy sense as a whole. So thank you again for having me today. Next slide, please. Just a quick snapshot on who is Stellar Health today. We serve over 1 million patient lives that we manage in value-based care or alternative payment models as a whole. We have almost 14,000 providers onboarded that use Stellar daily. And as a whole, we think of things in two ways. One is how much in reward dollars are we paying to all these providers and their staff monthly? You can see we pay tens of millions of dollars out monthly to these providers for doing the right work. And we're approaching almost 1 million healthy actions being completed in a year, which we're very proud of. We think of healthy actions as the building blocks of achieving in value-based care or an APM. I have a quote here that I'd like to highlight too from an actual staff member, office manager of one of our practices. And what I like to highlight is her statement that the solution not only rewards you, but gives you an immediate sense of accomplishment. I think this is a really important piece of what is missing in value-based care today, and we'll come upon that in a second. Next slide, please. So I want us all to start for a second and just think about, did you have coffee this morning and why? And what I contend to you is, it is a very common feedback and habit loop. I myself had coffee this morning. I wake up, need a little bit of wake up coffee, act on the behavior, and then I'm much better to prepared for the day once I've had that coffee. We all live in these different feedback loops on a regular basis, whether it is brushing our teeth to feel clean as we head towards the day, making our beds, whatever it may be. These habits are important and very powerful in how we actually carry out our day. Next slide, please. And so when we think about value-based care performance, we think a lot that the ultimate performance is a lot defined by these primary care and provider workflows. In addition to that, in order to improve the performance, we're going to require a lot of behavior change. We need these providers and their staff to do things differently than before. I tell you that just participating in an APM or a value-based care arrangement does not in itself mean you are achieving in population health or value-based care, that ultimately you must do things somewhat differently than before in order to manage that care, those patients' care at higher value, lower cost, and maintain very high quality as a whole. And ultimately, all these feedback loops and behavior change require real-time incentives to the people responsible for work. I think ultimately, one of the biggest problems we face in value-based care as a country is you have two problems ultimately that remain. The first is you have delayed gratification, right? So the way all these models work, you might do work in it as a participating provider or staff member, and ultimately, at best, you see the reward 18 to 24 months later. Can you imagine if I told you that your entire salary was instead going to be paid 18 to 24 months later? So the idea of this delayed of gratification, I think makes it very difficult for people to really want to jump on into these and succeed. A second problem that we also face is shared accountability. For those of you who have led and managed larger organizations, you will find that having the confusion of multiple people responsible for the same thing does not lead to great outcomes. That we end up with a tragedy of the commons if we do not have clear lines of ownership of who needs to do what. I think in value-based care, because you have to manage a population as a whole, you end up with a situation in which providers sometimes ask themselves, well, even if I do all these things, what about the rest of the ACO? If the rest of my providers don't also achieve 4 stars, or if they also don't do the transition of care visits, do we achieve the results collectively? So you have this problem of shared responsibility, which I think makes it difficult. Next slide, please. And I want to highlight one more thing that's really important, which is, from my perspective today, I think we see that value-based care penetration is a little bit misstated out in the real world. That in terms of the penetration, a lot of the focus still stays with larger organizations and the centralized organizations at the top. And the reality that I see is on the ground, it's really the attributed physicians and the staff, the medical assistants, nurses, front desk staff that work with those physicians that really drive value-based care action and change. And that one of our other biggest problems is we need to penetrate value-based care and the change down to those people who do it. And you'll see here an inverse arrow that points out that the importance of the delivery, the actual doers of the work, the people on the front lines are actually down at the bottom. But I ask you, how many of those dollars in value-based care, those bonuses, have flowed to these people down here? If they don't see the dollars, where is the feedback loop that matters to them? Next slide, please. So one of the things that Stellar does, and I think that any successful program needs to do, is you need to be embedded in the workflow and highlight at the right time the exact actions that help drive value-based care. Whether it is doing a mammogram, a diabetic eye exam, addressing a condition, doing a transition of care visit, making the right referral, any of these actions are what really happens day to day. We all know in this room that these actions drive tremendous value for the system when done right. So the real question is, how can we create the feedback loops that train all these providers and staff to do things slightly differently to achieve these outcomes instead? How can we reward in a way that ties the exact action that we wanted to the outcome that we really need? Next slide. And it's also important to note, when I talk to providers and staff carrying out value-based care in the real world, that we sometimes at the top trivialize what it takes to actually get some of this stuff done. That in order to achieve value-based care on some of the toughest patients, it actually requires more than just an open gap turning to closed gap. That it actually requires getting the patient on the phone or engaged, to getting that patient in, to scheduling the patient maybe with another doctor like a GI, and then also making sure the patient goes for their colonoscopy and shows up, and ultimately closing that out with full credit all around. The point here that I'm making is this stuff is not straightforward, not easy, and we sometimes look at it as just a binary 1 or 0, open or closed, when in reality, in the real world, it's a series of workflows that go right that end up leading to better patient care. So I ask you today to think about what are all those workflows and why should they be rewarded to make sure, again, we achieve the outcomes that we're looking for. Next slide, please. Finally, we think about this a lot at Stellar Health. And again, I ask that you all think about it in a similar fashion, which is there is a feedback loop that ultimately happens to why a provider or their staff may embrace more and more of the value-based care and success in it or not. The first thing they have to do is have the patients come in and see these patients. Already happens out there, but an important piece in the step. It is also important to prep these patients in step 4, right? Prep for these patients, make sure they understand what are the additional value-based care actions that may be required to truly address the patient today. Step 5, you have to actually see the patient and carry out these additional actions that is not part of your normal day. Susie may have come in for a sick visit, normal sick visit with the flu, but there are other things that you may want to get done to manage her as part of the population. You really want to use technology to update what has happened, whether it's in your EMR or in some other technology, You have to actually note that this got done and follow that patient along. And finally, to close the loop, we find it is very important to reward something we call here stellar value units or SVUs for when a practice does the right things in near term. By doing this, we change the paradigm to near term reward an immediate feeling of the satisfaction of what we accomplished, as well as direct individual accountability to that care team and not the group as a whole in general. Ultimately, I think sometimes we ask ourselves, why is it that in fee-for-service, we have providers and groups maximizing their RVUs? And I say it's because that's the way we designed it, right? And instead, if we design the system to maximize the value-based care actions, we will also see providers and their staff carry that out. Ultimately, I'll leave you with one last story, which is in my working with one of the national carriers, I was once with one of the market CEOs, and he said to me, "It's so interesting, Mike. You're saying if we just pay the providers to do the things we want them to do in value-based care, they'll actually do it." And I thought it was such an interesting, simple statement that perhaps what we have done is made it so complicated that it isn't clear what you want me as a provider to do and how to go achieve. And if we can make that incredibly clear, establish the feedback loops, we will see this take off as a whole. Thank you for your time today.
Thank you so much, Michael. Can't wait to ask you questions about that. Next up, we have Dr. Steve Furr. We are happy to welcome him as the president of the American Academy of Family Physicians. AAFP is also a previous submitter to PTAC with the Advanced Primary Care, a foundational alternative payment model for delivering patient-centered, longitudinal, and coordinated care proposal. Welcome, Steve, and please go ahead.
Good morning. Glad to be with you. And Michael, by the way, I don't drink coffee at all, so we'll see how this goes. So I'm Steve Furr, and when I'm not on the road as president of the American Academy of Family Physicians, I'm a practicing family physician in Jackson, Alabama. So coordination of care is very important to me, team-based care from a family medicine perspective. Specifically, we'll look at the extent to which formal clinical integration is needed to achieve care coordination and team-based care in the context of population-based total cost of care payment models. Next slide. So we look at this, some things we want to emphasize. Primary care is at the center of care coordination. And care coordination encompasses both physical and mental health. As we're learning, mental health is a huge component of what we do with our patients each and every day. It is a team sport, and it's led by the primary care physician, and that's the one that coordinates all the care. This care coordination encompasses both healthcare entities, also community-based organizations to help address health-related social needs. So this is where we're at, trying to address those social needs that our patients are experiencing each and every day. Next slide. So things to look at, clinical integration is a spectrum, regardless of how formal or informal it is. The aim of the clinical integration is to improve coordination of patient care across their conditions, their providers, their settings, and across time. So clinical integration is a spectrum, and it can stretch from very informal arrangements to collaborative agreements to full-blown legal entities known as clinically integrated networks. Some of the more formal clinical integrations involves an integrated platform enabling access to patient clinical data for all providers, collection of data on cost, program utilization and participation, as well as clinical outcomes, retrospective and predictive analysis, ongoing collaboration and communication between in and outpatient providers, including primary care physician and specialists. This should include information on the setting of care, the delivery, the assessments and treatments given, and the treatment plan going forward. So coordination of management of complex issues between providers and disease management programs. And in some cases, even having case managers assigned to each complex or chronic patient to make sure they get the care they need and the follow-up that they should. Next slide. So some points we want to emphasize here. Clear communication is essential. Expectations should be set proactively and clearly understood. PCPs and specialists need to have aligned incentives and must be mutually accountable. And patient preferences and incentives need to be aligned so that everybody understands where they're at and that they're on the same page. Next slide. While not required for optimal care coordination, formal clinical integration can help. Other things that can help facilitate optimal care coordination include communication, as we mentioned before, technology, and reduced administrative burden. You know, in all this high-tech world that we have, and I spent all day yesterday upgrading all my Apple devices from my Mac to my iPads to my iPhone to get the latest Apple updates. Sometimes it's the simple thing in communication that makes the biggest difference. I can tell you two of the most important people on my care team is a vascular surgeon and a breast surgeon that I use. And why do I use them? They always give me information about my patients and get it back. But most of the time, I don't have to even wait until I get a formal consult letter back. Often they call me directly from the operating room and tell me what went on. In that 2-minute conversation, I know exactly what happened to the patient. I know what the plan is. I know this patient with breast cancer, they're planning on doing chemotherapy and radiation in the order which you're going to do it. That 2-minute phone call will save me 10 to 15 minutes of trying to go through their patient's records and actually figuring out what is going on. So that care coordination is so important, but sometimes it's the simple things, just a phone call, the red flags that'll let you know what's going on with the patient and what you need. Next slide. So primary care physicians are the quarterback of care coordination, but it's a team sport with everybody working together. And as long as everybody does their part in the system, it works well. But it's so important that everybody also is willing to realize when things aren't going right or something's wrong, that they're willing to make a difference and step up. When some kind of data comes through the system that it's not, shows there's an abnormality that needs to be addressed, somebody needs to make sure that's taken care of. Just to give you an example, the other day I had a patient who had a chest CT that was markedly abnormal. Nobody in radiology bothered to pick up the phone and call. They just assumed somebody would look at their report that was sent back electronically. And because of that, this patient's care was delayed for a couple of days, wound up being in an ICU bed on a ventilator. They might have could have prevented if somebody just picked up a phone and called. So particularly when we coordinate our care, it's so important for our patients that then there is that red flag, the thing that really stands out, that in all the sea of normal lab and lab data and lab information, something's abnormal, that somebody says that's a trigger, we need to address this, we need to deal with that. So that clear, effective communication. And I can't emphasize how important it is, the coordination between the different specialists. You know, I think so many of the specialists now are trained in these vertically integrated systems, and they assume everybody in the world is on Epic, so they all have access to the same information. So I have some specialists that rarely send me a letter back, even though I send them a patient down. They're not in my network anymore because I no longer send them any patients, because it's a two-way street. I learned about what they've done for my patient, but they also educated me about how they're taking care of these problems, the people who need surgery, who don't need surgery, who treat different. So I think it's really important that we continue to train our physicians, that it's important that they continue to communicate back and forth, and that's a two-way street, that our patients get the best care possible. Next slide. So financial risk needs to be at a level above that of the individual physician. Financial incentives need to be aligned among all the involved, including the patient. Value-based insurance design, including coverage consistent with patient-centered care plan, can help align patient incentives. And the patient's primary care provider needs to be the ultimate owner of the integrated patient-centered care plan, covering the multiple touch points across the continuum of care. Next slide. So the key takeaways: optimal care coordination does not depend on formal clinical integration, but can benefit from formalized accountability. Effective care coordination starts with promoting proactive, longitudinal primary care, and those relationships between the primary care specialist and the specialty care need to be communicated and facilitated by clear communications, effective data sharing, and alignment of patient preferences. And so much comes from the clear communications, not depending on hoping somebody's going to read an email sent through, or they're going to read data that was put in there. but that communication needs to be sure the follow-up on the patient when something's abnormal, somebody's addressing that and making sure that's taken care of right at the point of care. So appreciate your time and looking forward to the other presenters and answering questions. Thank you.
Thank you so much, Steve. Really interesting presentation. Next, we'd like to welcome Ms. Jenny Reed, the Senior Executive Officer of Southwestern Health Resources. Welcome, Jenny. Please go ahead.
Thank you. Good morning, everyone. It's nice to be back with you. My name is Jenny Reed. As it said on the introduction, I'm a licensed clinical social worker. I've spent the last decade plus in value-based care, but came to it through a role of coordinating care for the most complex patients that we took care of in our healthcare system. So I speak a lot from that point of view and finding places we can coordinate better. Southwestern Health Resources, if you'll go to the next slide, just to give you a little bit of background about who we are and what we do. We're located in Dallas-Fort Worth. We are a combination of two large healthcare systems, one being Texas Health Resources, which is a large community-based healthcare system, acute care hospitals and specialty care hospitals, ambulatory surgery centers, standalone imaging, et cetera. And UT Southwestern, which is a large academic medical center here in Dallas-Fort Worth that does a lot of teaching and has depth and breadth in specialty services, as well as physicians in our community hospital, Parkland Healthcare System, and Children's Health. The physicians from UT Southwestern serve both of those community resources as well. So in 2016, these two organizations came together to work collaboratively on value-based care initiatives and form a clinically integrated network. And what you see on the timeline below, I won't read all of the points to you, but what you'll see is a journey from forming as an organization, having already started to, UT Southwestern had already started to participate in Medicare Shared Savings, upside only program. And in 2017, we moved into a next generation ACO. We participated in Next Gen until the time that it was sunset and moved into ACO Reach, where we are currently participating in the global and professional direct contracting model, and we'll be moving into PCP CAP in 2024. So we've generated $223 million in savings. We've shown lots of success in this model. And on the subsequent slides, what I'll do to explain how we could get specialists more involved is kind of give you a real world example of what we experience or what a Medicare member might experience in the DFW market. Next slide, please. So this is a different point of view of our network, 1,500 plus primary care physicians. That's the largest primary care physician aggregation in the DFW market. 4 months ago, and last time I spoke to PTAC, I worked for Baylor Scott and White Quality Alliance, which is the other not-for-profit ACO in this DFW market. We there were the top performing Medicare Shared Savings program. Southwestern Health Resources is among the top ACO Reach performers. And like I said, the largest aggregation of primary care in the market. You see that very large specialist number. Those are heads, not necessarily FTEs. As I mentioned, UT Southwestern is a large academic healthcare system. And so a lot of those physicians wear a couple of hats in teaching, research, and actually seeing patients. But also in that number is a large amount of community-based independent specialists that we work with. And, you know, we really, our goal in both the primary care and specialist space is to help independent physicians stay independent if they can, and make these models accessible to them in a way that they can continue their practice despite the financial pressures that we're all experiencing in healthcare today. So when you look at that specialist number, those are academic, employed, and independent medical, surgical, and hospital-based specialists. On the next slide is a little bit more detail about how patients and specialists might experience our ACO, but just as an example of what I think happens across the country to specialty care providers and facilities who are trying to deal with these Medicare advanced payment models. So as I mentioned, we're one of the largest ACOs nationally. We have 125,000 lives attributed in our ACO reach. So you see that in green on this line across the top. In the pink is our total attributed Medicare Advantage lives attributed to our primary care physicians in our accountable care organization. And then the rest of the lines, the red and the blue, are the rest of the Medicare lives that we're serving in our clinically integrated network. And those are being seen by our specialists and in our hospitals and not attributed to our ACOs. So the point of having all of the different logos that you see across the bottom is to illustrate that most of the organizations, in fact, almost all of the ones pictured here, have their own accountable care relationship with CMS. And we're all accessing the same resources in terms of specialists and hospitals. So when we look at primary care attribution, I think it's really hard for specialists to figure out how they relate and to really get involved in a meaningful way with all of the various organizations and what they might deem their requirements to be or their preferences to be. So I have a few suggestions about how we can fix that. Wanted to show one more example on the next slide. Using our SWHR data, again, 125,000 covered lives, one of the largest ACOs in the country. We got some shadow bundle data based on our 125,000 lives. And my arrows aren't quite lining up as they should, but if we look at major joint replacement, that's 1,850 total qualifying bundles. You can imagine for some of the smaller ACOs that maybe have 30,000 lives, that number is going to be a whole lot smaller. But even for us, across 12 months and probably 250 orthopedic surgeons that perform this procedure, it's not a meaningful number or a number that providers can feel like really is evidence of what work that they do, statistically significant work being done. It's also a scheduled elective procedure, which is very different than folks who are admitted with a fracture, which usually is the result of trauma. And you can see, again, 35 across 12 months and 125,000 lives. When you look at taking action on that in an ACO that's more average size, 30,000 lives or so, the numbers just don't accumulate in a way that it can be meaningful to specialists for participation. And those are surgical specialists. When we talk about medical subspecialists, I think it's a different ball game because oftentimes they are managing chronic disease. And I know we've done some innovation in oncology and ESRD as far as helping those physicians that are managing as the primary provider of care, even though not typically PCP. But there are more in, ulcerative colitis and Crohn's disease. Probably that's a GI physician, et cetera. So on the left, just some more notes of what I'm describing. Sample size is too small to be useful in a nested episode in most ACOs. The logic doesn't follow what's clinically expected. Again, scheduled elective procedures ought to be a whole lot easier and probably very different to manage. When you look at the shadow bundle of an inpatient fracture, that's a trauma, and the majority of the spend there is a patient sitting non-weight bearing in a SNF. So the amount of time assigned to a nested bundle ought to be based on clinical course, not just a standard that we've assigned a number to. Earned incentives are delayed and small. I agree with what I think Michael said earlier. Paying doctors 18 months after they do a behavior is not consistent with behavioral economics or just human nature. The calculations are opaque. How do I understand? We participated in BPCI Advanced when I was at Baylor Scott and White, and I think paid reconciliations for 3 years after. Again, I don't know that really links what I did for a surgeon or any physician. What did I do with how did I earn or not earn a reward? And so specialists lose interest and the program loses relevance. And then we just go back to, do you get to receive my referrals or not based on whatever I define as behaviors I want to see in a specialist? And I think that is a way, but it's not a meaningful way to really engage the hearts and minds of physicians in participating in these programs. So I've listed some potential solutions on the right, aligning ACO and facility to encourage collaboration. So if we think back to the slide I had up previously, there are hospital or healthcare system sponsored clinically integrated networks. But how would we encourage primary care only ACOs to connect to both specialists and facilities to mutually create value and participate in the value that's created, including quality and cost metrics relative to care setting and provider. As I mentioned before, these episodes and specialists are not created equally. Reward transitions back to the community provider. So that's a simple way of saying what I think was said right before is, if you give the information on what happened to my patient back to me, maybe there's a reward for that, and that starts to get us more integrated and coordinated. Allow ACOs to opt into nested bundles rather than requiring. So using this data on the left, maybe I would opt into the first two, but obviously the last one, 35 encounters over a year, maybe not as exciting a risk venture for me to take right out of the gate. Include clinically relevant providers and timeframes. This is healthcare is a team sport. And then establishing low volume thresholds. So those are some potential solutions for nested bundles. On the next slide, a little bit more about specialist participation in general. Sharing all relevant data all data relevant to the use case. What I mean there is CMS has data, longitudinal data or provider-based data across how they've provided care to all of their lives, Medicare lives. The only thing that ACOs can see is how a specialist has provided care to their specific attributed lives. What that does for specialists is can unfairly represent how they're providing care. So in a similar way to what we do to primary care when we attribute lives to them, maybe there's a way that we could create specialist data sets that say, here's how this particular surgeon does surgery on a broader, more statistically significant look, rather than just, the few episodes that happen to occur within your ACO. Give episode data with national and regional benchmarks, maybe something with stars, et cetera, to inform patient choice. Use standard definitions that are transparent and relevant to the clinical scenario. And like I said before, ensure sufficient sample size. Aligning program design elements. So ECQM and MIPS should remain aligned to broad outcomes created by all providers. Again, this is a team sport, not taking it to specific metrics that wouldn't be significant or represent the course of care for a patient longitudinally. QP bonuses today penalize ACOs who include unattributable providers. Let me pause here for a second. So because of the way the QP bonuses work and the percentage of revenue that's involved in an APM, what you see typically is that healthcare system CINs include specialists and primary care independent ACOs include primary care. When you add specialists, you have to look at their entire book of Medicare business and what percentage of that is involved in an alternative payment model. Regardless of what I already said, not all of those patients are attributed to the ACO. So you create a disincentive to include specialists in the ACO because of the way that math works. So said differently, if I include an orthopedic surgeon, I'll just use them because we talked about knees earlier, in my ACO, and they see 100 Medicare patients, but only 20 of them are involved in my ACO or any ACO and APM. Now I've got 80 patients who count against me in my percent of Medicare revenue for my providers that are coming through an advanced payment model. And that jeopardizes my ACO's ability to earn a QP bonus. And that And that in and of itself is a disincentive for ACOs to go out to the community and include providers, specialist providers for that reason. So that has to be something that is fixed if we want to include specialists. I think specialists probably need to be able to participate in multiple ACOs, just given the data that I shared on my first slide. There are lots of ACOs in the community. Tighter alignment benefits patients. So allowing them to count theirs across multiple ACOs would be helpful. Updating attribution logic to include a greater number of specialist panels for those medical subspecialists that are the provider of record, because they're managing a complex disease. They should be able to get credit for driving that care, similar to how we've done oncology and ESRD. And then make advanced payment option available to all ACOs regardless of revenue. We talked earlier, one of the speakers talked about low revenue ACOs. I'm a lot on the advocacy side of high revenue ACOs, because I think we get sometimes a bad name. But because we are including all of these specialists and facilities, there's a longitudinal care element that I truly believe is part of the solution for value-based care. We have to include all the providers of care. All of us have to work together to create value, and we shouldn't be penalized for taking on a broader swath of care. And so I think the revenue, high revenue, low revenue, can disincentivize both small providers who don't have a lot of capital access to join these programs, as well as high revenue providers who really are trying to coordinate a more complex set of participants. So those are my thoughts there. And I think I have one more slide that is about patient involvement. And I believe it was our first presenter who said the patients need to have an incentive to participate. I couldn't agree with that more. There are a lot of elements for patient choice and to protect beneficiaries from exploitation that can occur in these kinds of programs, and I totally agree and support that. However, the patient involvement is key to success. Without incentivizing them to understand what they're participating in, to understand their choices, and to make smart choices about how they can participate in their own health, we are still going to be a paternalistic healthcare system speaking at people instead of working with people, and we have to fix that. So I have a couple of bullet points here. I'll just go through them real quick. Redesign notifications so that beneficiaries hear what they want to know, not what legally we think we should tell them. Allow ACOs to customize so that they can combine with other communications that they're giving. That may get the patient's attention better, and increase flexibility to provide beneficiary incentives. On the last slide is just a conclusion. Again, make it easy to understand for specialists to participate, make it easy to understand and join, allow advanced payment options and broader participation, and incentivize patients to participate. Thank you for your time.
Thank you so much, Jenny. Really interesting presentations. So we're going to go to questions from committee members next. If you have a question, please tip your table tent up. If you're on Zoom, please raise your hand, and I'm going to take the opportunity to ask the first question while you're warming up. So we know in focusing on achieving care coordination, the recommendation is really looking at multidisciplinary team-based care that's longitudinal to really have holistic care coordination. So I'd love to hear from each of you what roles or disciplines you've seen as most essential and successful in achieving the care coordination outcomes that we want to see in alternative payment models. That's the first level of the question. And then the second level is, what are the financial incentives that actually result in growth of those roles and achieving the outcomes that we want to see? So I'll open that up to whoever wants to start first, but definitely would love to hear from each of you. And if you don't jump in, I'm going to go to Michael first.
Sure, I'll take that one. So in my experience, I don't necessarily think there's a role that is special or makes the difference. And it's not because I don't think it's important. It's that I think in every practice, it's someone different sometimes, and the role can be called different things. So in a large group, you might have nurse care coordinators, right, that are absolutely essential to this. I think what I find is that your 5-doc group, though, a smaller group, it might be the front desk staff. So I don't necessarily say it's this title or this role that makes that difference. I think what it actually makes a difference is the work they do. So I think the work we could all agree on is kind of the same. It's making sure patients navigate to the right place. It's making sure that when they're out there in the wind, we get them in and all these different things, right? So I think we can all agree on that. Again, I don't have a title that I like to use. I think in different groups, there's different ones. For me, though, to your point, it's all about making sure they're rewarded. And what I find absolutely fascinating, right, is a lot of these people, if you actually look at maybe what they make per hour, we're not talking about a lot, right? They're competing against the people employing them are competing against IHOP down the street. That's a real story, by the way, of losing these people to IHOP who are offering $25 an hour when inflation really hit. And so for me, the really interesting thing is how can we just pay them a little bit more? And oftentimes I find it's not so much that they care so much about the money, right? It's also about the thank you, the gratitude that represents when you ask them to do more work, that they're actually rewarded for it. So I think the most important piece of this is they're very much the backbone of our healthcare system. Not that providers are absolutely important too, but I think we share some portion of the dollars to these people, and they will step up and do a lot more of this work.
That's great, Michael. And have you seen the incentives in your model actually result in an increase in those roles, or is it more just increase in their payment?
No, we actually, it resulted in an increase in a couple different ways. So one, we actually did see groups start adding more of this role over time. Now, some of our larger groups, they're earning hundreds of thousands of dollars, maybe up to millions. And to me, that's actually the ROI machine. And forgive me for being a bit of a finance student here, which is, I think in order to make this work, the provider side needs to see a return on their investment first. And then they can invest that back into these people and hire more of these people who generate more in return on that investment again. And that's how this ultimately results. But the second thing I will also highlight, and we did this study with Healthy Arkansas, which is a lot of the larger health systems there, which we are implemented in. And we also found that patients who are the care coordinators and staff members who received this small extra dollars actually scored about 10 points higher on their employee engagement survey. So much so that the health systems were perplexed at a time when it was hard to retain these people. Like, what was it that was so different about this? And a lot of the comments were, it feels like you guys actually appreciate the extra work. When you ask me to stay late till 7 p.m. to do this extra call for the patient, that I actually, you appreciated it versus just expected me to do more to burn out. So I highlight that it's employee satisfaction as well as the fact that we can actually add more of that capability.
That's great. Thank you so much. Steve, would you like to comment?
Yes, I think one of the most important things is who actually is in charge when something in the system breaks down. I think that ultimately goes back to the primary care physician, because when the system does break down, you need to know why it broke down and how do you fix it. These problems still don't continue to go on. So, for example, when home health sends a patient to the ER without calling me first, and something I could easily could have handled over the phone or brought them into the office, I don't need home health to send them to the ER. I need them to communicate with me what needs to be done. Or as I mentioned, the CT scan the other day, nobody called me the results that could have been taken care of. So ultimately, I think the family physician's got to make sure, the primary care physician has got to make sure when things do break down, why did it break down? When your subspecialist doesn't give you a call back or he doesn't send you a consult note, you say, I've got to get me another specialist here on the team. So I think ultimately that's important. I think in addition of financial incentives, I think everybody on the team is excited when you see you made a difference in a patient's life, that you saved that diabetic leg, that you kept that patient from going dialysis. So I think sharing those wins, not only when things break down, but when things work really well, my people get really excited about that and they know they made a difference. And ultimately, we all went into medicine because we want to make a difference in our patients' lives. So I think that makes a huge difference. But financial incentives do help, and I think positive incentives help. I don't think negative incentives really drive physician behavior. I think we have a history of having a really weak carrot and a strong stick, and I don't think that helps physicians. I think the reason they've steered away from a lot of these models is that they see they have to do a lot of work to get a 2% gain, but if they don't do it, they take a 7% loss, and that doesn't encourage anybody to participate.
So helpful. Thank you so much. Jenny or Alice, would you like to comment? Jenny.
Sure. So I think that the roles that we have seen be the most helpful are really the most important one, I guess, is risk stratification, because the role of a nurse is more important for a complex patient who doesn't understand what's wrong with them or what they should do next. Whereas I think the gross majority of people just don't understand how to access healthcare. And so that advocacy and navigator role that Michael mentioned has been super helpful, not only to make sure that we generate our outcomes, but also to Steve's point, to take some of the burden off of the physician. We found that even depression questions were hard to add to the physician's plate. But when we could say, hey, if your PHQ-2 comes out positive, we have a social worker that's going to do the 9, and that's also going to address the issues that are discovered in that process. Okay, well then that's a little bit of what happens to my day. As far as what happens to my pay, I think we have designed incentives that are aligned with overall outcomes. So there's an annual goal or target set of goals that we need to meet. And when we do, we reward all the way down to the frontline staff. We don't reward on an individual activity basis. But I do believe in changing the economic model. I think the more these programs can change the economics of fee-for-service to value, the better. What I think we have to be careful not to do is create another production model or just another RVU, and make sure that I feel pretty strongly about connecting to outcomes as much as possible, because all those dollars come from somewhere, and they're being spent on a patient today. And so we have to make sure that it's not needed for that patient tomorrow in order to connect those incentives correctly.
It's a great point. Thank you, Jenny. Alice, please go ahead.
Yeah, I think from what you've heard from the panelists, my interpretation from what everyone has said is essentially there's a variety of different disciplines and roles that are maybe specific to a given organization. And I just wanted to mention the Healthy Hotspotters randomized clinical trial. I'm not sure if the panel is familiar with that trial, but essentially in Camden, a team of nurses, social workers, community health workers all went to coordinate care for some of the highest risk patients with this idea that surely there will be savings. And there wasn't. And I think that was a surprise to everyone. And I think part of the challenge here is knowing that not all organizations are the same. In fact, they're all different. And so being able to pinpoint a certain title or role or person that would be most successful in a given organization across all organizations, I think is not it's not something one can identify or answer really well. But definitely agree with the need to make financial incentives at least present for the people who are doing the role.
Wonderful. Thank you. Larry, let's go to you.
Great session. I always enjoy listening to speakers that are on the ground dealing with this every day, and all of you are in that space. As a specialist, I typically bring up the specialty-focused issues, and although my question's going to be focused towards Jenny, any of you can participate in it. You mentioned that you are attempting to bring in value-based payment programs for medical specialists, and you specifically mentioned oncology and gastroenterology, and I am a gastroenterologist. So much of the work the care we provide today requires expensive pharmaceuticals. So my first question is, are you including in total cost of care models for your ACO, medical as well as pharma-based spend? And if you are, how are you utilizing that to make sure that the specialists are providing the right drug to the right patient at the right time for the right reason?
I would love to tell you that we have cracked that nut. I will tell you that we are committed to furthering that. Yes, we do include pharmacy and medication. We also own a Medicare Advantage plan. So we've had some successes and, to be real honest with you, some failures because of the headwinds of pharmaceuticals and all of the other legislative changes that have occurred. But we do see wins in things like medication selection is one. So making sure that we understand all the biosimilars and are they really similar, but also site of service delivery for those medications and where we can do that in the least restrictive environment. And then patient adherence to those, because we know what costs can occur without proper adherence. But yes, to your point, those are going to continue to be some headwinds that we have to work through. But including the medical specialists in the conversation is the first step to get that solved. And how much time and expense is part of the workup and the what's wrong that we could potentially take out and make better for the patient. So I don't know if that totally answers your question. I think we're on the beginning side of that. And I think CMS with the ESRD model and the oncology model has done some experimentation there too. That's helpful. I think they should include GIs. I think you need to be a part of it. I think, pulmonary physicians need to be a part of it for COPD, cardiologists for those complicated heart failure patients. We penalize hospitals for readmitting the heart failure patients, but where's the incentive for the cardiologists to really manage those patients? In some cases, they can be attributed. In a lot of cases, they're not. So it's a combination, I think, of designing the right program and then clinically, if that medication is required, negotiating the right price and allowing for the treatment to occur that prevents the disease from progressing.
Thank you. Great answer.
Any of the other presenters want to comment? Please go ahead, Michael.
Yeah. Well, Larry, that we actually recently were commissioned by a large national payer to drive value-based care in specialists. So this is a very important topic to them. They actually looked at a number of specialists, including GI, that almost act as primary care, right? Again, we sometimes only think about Medicare, but don't forget that for women aged 20 to 40, your OB-GYN actually might be your primary care physician, essentially. So we looked at about 5 or 6 of these specialists that essentially are being used as a primary care quarterback, and we're actually going after them in the same way to try and drive these things. Now, you bring up the pharmacy side of things, and we have a couple clinics that are very high in HIV, for example, and that is incredibly difficult. We've never been able to get a value-based care contract or APM set up properly there because that spend is just so different, and neither payer or us can figure out how to do that in a way that is meaningful. But again, I will say, I think the tide's starting to turn, that specialists are being included, especially those who really direct a lot of the care for these patients. And I'm pretty encouraged by that.
Anyone else? And as presenters, I want to encourage you as well to comment on each other's comments. The dialogue amongst you is very valuable. We appreciate all of your expert opinions. So I'll go next to Lee.
Thanks. This is mainly for Alice, but others will have comments, I'm sure. I'm fascinated by your third slide, just showing that participation ACOs has been strongly skewed towards those better performing at baseline with benchmark spending less than their regional average. Obviously, conceptually, the greatest aggregate gain would be those moving from terrible to average, not good to great necessarily. So focusing in on that specifically, why do you think that is? I think for me, it's more about culture of those lower performing ACOs, perhaps, and leadership vision than economics. But I would just love your insight to why you think that is. And then that leads to the next follow-up question. What can we do to change incentives or models to get the higher performing aggregates of doctors and ACOs or worse performing to actually engage in this journey?
It's a great question. I think what we've seen is essentially over time, the ACOs that are entering are becoming the better performing ACOs, right? Those that, as you said, already spending low relative to their regional average. And part of this is because in 2019, when we introduced pathways, we started penalizing ACOs with higher spending than regional average. We started putting into their benchmark essentially a stricter updating factor that required them to do, to have larger savings in order to be able to have any incentives, right? To be able to have any dollars back, paid back, bonus payments back, relative to the ACOs that were already spending less relative to their region, right? So it's that was a mouthful. All that to say, we made it harder for ACOs with higher than regional spending to participate because we made their benchmarks harder to meet. And I think that is something that we should really pay attention to. And that's in part why I think that the blending of the regional benchmark should be done at a very gradual pace, because those are the high spenders are the ones that we want in the program.
Anyone else want to comment?
Just gonna add, can you hear me? I'm having trouble coming off mute. I was gonna add the converse of that is true, is also true, Alice, right? So the high spenders end up exiting because they're higher than regional benchmark, and the ones that were low spenders now have a delta that they were never able to achieve before. And so their willingness and ability to take risk increased in 2019. When they kind of got credit for a regional benchmark, because performing against yourself when you're already performing really well is not a place where you want to place your bets. So I think that's where you saw those high performing ones kind of double down and the lower performing exit.
Yeah, absolutely. And I think part of this is also, Jenny, as you mentioned, essentially this rebasing and this ratchet effect we want to make sure that we definitely protect against.
I'll add one more comment too, and we have an MSSP ACO, so I do think about this a lot in terms of, I think the issue is also that, don't forget that we're asking these groups to take insurance risk, right, essentially, and when you're doing that, one of the things I think is maybe understated is the potential risk of ruin. So the idea that something can go so upside down that it could, blow up the ACO as a whole, I think is not fully accounted for. And so I think if we want people to take the risk on the higher cost patients, I think we want to make the risk corridor more aligned to that so that they are willing to take such a risk. I think as someone who runs an ACO, it's easier to say, I'd rather my consistent, clear performance than to maybe take a chance on something like that. So that might be a part of it too.
Thank you, Michael. Let's go next to Jim.
Thank you. Thank you all for your excellent presentations. Michael, I'd like to direct this question. You were commenting, and I was struck by the perspective of incenting through proximity of reward toward the activity to the strategic value unit. I think you call it SVU. I like that. I wondered, and I saw in your example kind of how you do that, and I was wondering what other elements do you reward? For example, and do you measure the code, like the reward for, let's say, coding accuracy, and it produces a unit of work and there's a unit of reward attached to it. Do you have the same thing for your providers relative to care management? Then what % of the reward systems are structured so they're for coding versus care management? I'm thinking care management like referral completion and the patient made it to the specialist in a timely way, completion of health-related social needs screening and addressing the actual gap in the social need. Is that part of the activity? Okay, that's question part one. Then the second one, talked a little bit about the rewards, and I got the impression that they were provider-based rewards. And I was curious about, because some of the work that I do identifies really staffing and labor issues as one of the top issues inside the ambulatory space. And I was curious about how the rewards are actually allocated. Are they all provider-based rewards, or do you have staff rewards as a percent of contribution? And the same question would be for the specialist. Do you have a percent of the reward system for the specialists that are participating and helping make the value of the outcome in the value chain?
Great questions. So the first one, I'll say we're very proud of this, that we architected ourselves in a way in which anything you would want to incentivize your heart's desire in value-based care, we write up actions for and then incentivize. So to your point, transitions of care can be important. To your point, referrals can be important. We're actually testing something right now on switching to ambulatory surgery centers, right, which is a really hard one to do, by the way. The point being here that absolutely care coordination is a big piece of it. I'm also pretty proud that we're partnering with some of the 1115 waiver in New York, because we also have sufficient density of providers here where we're going to actually be the ones administering the social determinants dollar rewards for those specific activities. So you're absolutely right. That's an important piece of it. We're not trying to just incentivize coding or one thing. And so I think of it as, I'm not the expert on what do we want to drive. I think you all are. My job is to make it so that you can incentivize it and drive it. So when we partner with someone like you to set up a program, you actually have your say on that. And I'll add that the SVUs is dynamic. So one of the things I'm a little frustrated with that you all know well is that the physician fee schedule in RVUs is actually updated once a year. It's fairly fixed. So once you've done that, it's stuck. Stellar, our SVUs are actually dynamic. We can change it down to monthly or weekly or daily if we wanted to. We don't do that because that would throw people a little bit, but we can. And that's important because you want to change in different parts of the year or different populations the amount that you're rewarding for different things. What we've actually found too with providers is as long as what you see is what you get up front, so no over-applies, under-applies, overpayments, all these other things, providers actually are okay with the changing amounts as long as it's clear up front what they would have earned for it. So all that is to say, you're absolutely right about the direction this needs to go in, and we want to partner with folks who know what they want to drive to go drive it. We're not experts ourselves necessarily in the different things in your population. And specialists, I will say that we don't actually have that fully figured out yet today, and I'll come to that in a second. And then on the staff, you hit the nail on the head, which is we actually encourage sharing about 20% of the earnings with the staff member who logged in and actually did the work to tee it up for you. We find that ratio to be a pretty solid ratio. It can range. We let every medical group choose for themselves in the end. But we have found that when you share 20%, oftentimes it results in a staff member earning about $300 to $500 extra per month. And that amount goes a really long way for them while also driving significantly better results for the group. So yes, absolutely exactly how we think about it is how you stated it. And that has actually been, I think, a big key to success.
Warren, can I follow on? And Jenny, I'd be remiss. We have history goes all the way back to Baylor, 20-something years ago. I'd be remiss not to ask you the same question. I had a couple, I'm going to tee it up a little bit. So I'm just pleased with hearing the success of this SWHR organization and its scale. I think that, when I watched this while I was in the system, working in the Dallas-Fort Worth metropolitan area and watching the competitive nature of what was happening and the consolidating physicians around value-based movement is really quite remarkable. And it is a study in itself. And it's really informative. And I think the scale that y'all have reached and its marketplace lessons that it has to teach us is incredible. So thank you for bringing those statistics and helping us see that. the potential for positive and negative, what we're seeing in our work is the potential for positive and negatives for at any scale is something that we're trying to harvest. And particularly around the topic of cost, quality, and equity. And so, and I know that's something near and dear to your heart, and that's kind of what we worked on when we were working together. So I'm curious about this idea of improving quality and improving equity while saving money through engagement of specialists. There's 5,900 specialists in your network. Some of them are probably community-based specialists with one of your JV partners. And I'm curious, are they being rewarded with the large amount of savings that the ACO has made over the course of its 4 or 5 years? You know, you started with, well, you're now in ACO Reach. And are you rewarding the staff, you know, because they're helping make the value, making these rewards? I'm just trying to understand how large organizations do this and how instructive that might be for us as we think about endorsing, you know, significant models.
Sure. So, hi, Jim. Nice to see you again. So I would love to tell you again that we have it all figured out. Here's what we have done with ACO Reach so far. As far as, you know, well, let me start with incorporating cost and quality, quality and equity into total cost of care. To me is an easy connection to make. I don't know that the lines are always, it is a process that has to start, that has a little bit of a delay reward, but once it starts being rewarded, it's easy to see how the dollars invested in improving quality of care and access create overall savings in the DFW market because of the massive amounts of growth we have experienced. We don't have enough houses, and we also don't have enough hospital beds. So there is a value proposition, I think maybe a little bit unique to our market, that it's a needs-based, value-based care, as well as a reason, you know, an incentive aligned to creating more value. We also don't have enough places to take care of people. So being more proactive and creating less demand on our limited healthcare systems is positive in 2 ways, because of the value it creates and because it frees up space for those who really need it. So we're trying to capitalize on that as much as we can. And really take advantage of the opportunity to better manage Medicare patients. In the specialist space, we are at the beginning of designing how we use our ACO Reach prepayment dollars, which ought to be available to more than just ACO Reach as we think about what we continue with and how we limit the participation of high revenue ACOs. I applied at Baylor Scott and White Health for ACO Reach and was denied, despite being the #1 performing ACO in the country, because, well, we weren't given an explanation. My suspicion is because we were a high revenue ACO. But being here at SWHR, what that is going to afford me to do is create economics with specialists in the market that incentivize them to work on cost and quality the same way primary care is. And that's what we're looking forward to doing. Haven't done specialists yet, but have done post-acute care, Jim. So we've contracted in our APO network with skilled nursing facilities, rehabs, home health for a rate different than what they would have gotten from fee-for-service Medicare, and a withhold and a payback, earn back for quality and total cost of care performance. So length of stay, readmissions, those types of metrics rewarded in the funding pool that's created by the advanced payment contracting option, the APO option that we took advantage of. Experimental, better with facilities than individual independent physicians in a very competitive market like DFW. But the plan and goal is to now go to specialists and create the same so that we can figure out, like I said, right now that the market is basically, if you want to continue to be in the network. Like Steve said, if you want to be one of my specialists on my list, I need you to do these certain things. And we're doing those types of arrangements, certain criteria to be eligible to participate. But if we don't change the economics, those incentives won't last alone. And then I think your last part of your question was about staff level incentives. Because we are part of large healthcare systems, we have to this point, and I've been at SWHR for 3 months, so maybe this is different next time we talk, but right now we've adopted the health systems practice of setting annual KPIs, and the staff, all the way down to frontline staff, is rewarded for those. And those are based on outcomes like total cost of care, savings in our CMMI, emergency department utilization reduction, avoidable admissions and chronic disease, the same metrics that CMS is measuring us on. We tell the staff if we succeed in those measures, we'll all succeed together. And that has been incentivized so far. But I also noted that Stellar Health is located in Grand Prairie, Texas. So maybe we brainstorm together, Michael and I, and we figure out, I don't know, something, some way of working together. I am just a little bit cautious again, because in primary care or physician-only ACOs, the dollars created are often created by creating cost in another part of the healthcare system, whether it's extending length of stay or forcing certain options in post-acute care. And I think the better service to our collective industry is to figure out how all members of the team, hospitals, post-acute, specialists, primary care, nurses, social workers, get to create value together and then participate in the value that's been created. As long as we create winners and losers, we're not going to have a sustainable healthcare system that serves all comers at varying degrees of need.
Thank you so much. We've got about 5 more minutes left. And Chinny, I'm going to go to Walter, and then Chinny, and then Jay, and we'll wrap up.
Thanks. Fascinating presentations. Thanks for being here with us. Just a few quick follow-up questions on Stellar Health's model with Michael. This idea of a quick feedback for desired behaviors is interesting. It appears to me, Michael, that most of the examples you brought up were rewards for process-related metrics, like calling patients, ordering mammograms, a diabetic eye exam, that kind of thing. A couple questions here. Does Stellar Health reward for outcomes, like a certain hemoglobin A1C or a certain level of blood pressure control? And then secondly, there seems to be kind of a bright line, perhaps, where it becomes really uncomfortable for rewards. So, for example, the Stellar Health reward for prescribing generic drugs instead of brand name drugs, right? Or does the Stellar Health reward for using a certain type of less costly orthopedic implant compared to a more expensive one? I mean, there might be some kind of anti-kickback ramifications. And the last question is, we heard a lot about beneficiary engagement over these last couple of days. Does Stellar Health ever reward patients for certain healthy behaviors or even just showing up for their appointments?
Yeah, great questions. So on the first one, and I'll try and keep it a little bit tight here. On the first one, we do reward for the outcomes that you refer to. So controlled HbA1c, hypertension controlled, any of the ones that are normal HEDIS measures, absolutely. Now, the thing I'm actually a little cautious about when we talk about this, though, is I think when we thrust upon larger, grander outcomes on providers, that's where it gets a little unfair, right? So controlling that patient's A1C, reasonable. I think asking that we hope that we reach 4 stars when we don't know the cutoff for HbA1c as a population as a whole, harder for them to track individually, right? And so what I think we aim to do is say, you control what you can, Mr. Physician or Mrs. Physician, in that moment, but then outside of that, the whole population is being managed by our technology. So what we actually do is we track the conversion rates of all those different steps to see if it actually resulted in the outcomes we wanted. And that's how we actually price the things we're talking about. So if you want a bunch of transition to care visits done, not everyone is going to get done right away. What we do is reward for them, and we see what the conversion rate for that provider may be and adjust accordingly to educate them that all transitions of care, you want to do as many as possible ultimately. My point to you is that the outcomes, when we try and make them really grand for an individual provider, I think get really hard to track across all their lines of businesses, Medicare versus Medicaid versus different payers. I think that's where technology should do the work as a whole. And then in terms of your second question was around, sorry, remind me.
Kind of rewarding certain types of clinical decisions like prescribing generic drugs.
Oh, right. So similar to my answer earlier, what we try to do is form in those situations a clinical committee that decides that they want a certain clinical protocol, such as referring to a certain place within maybe the clinically integrated network or prescribing a certain formulary or drug. And what our job is using incentives is to drive the whole group of providers to adhere to what that clinical committee decided. So we don't really directly make these clinical decisions ever. We do not practice corporate practice of medicine. But what we're trying to do is say, you all physicians came up with what you think is the right standard. Let's actually reward people for sticking and adhering to that standard instead of maybe following their informal golf buddies recommendation for that specialist, right? So those are kind of the ways we really focus on this. Again, I'm not the expert on what the clinical intervention should be. You all are, but what we can do is drive the whole group to follow what you've suggested in the first place.
And then the last one was the beneficiaries. Do you ever reward patients themselves?
Yeah, great question. I get asked this question all the time. And what I've found personally is I don't see the full ROI or benefit of doing so. And I may be wrong about this, but when for example, I don't know if any of you guys ever done a, gym bet with your friends where it's like, oh, let's all commit to go to the gym 4 times a week. And, whoever, does it all the time at the end gets the reward and those who don't lose, right? I found actually that I didn't do any more or less of it as an individual human. I don't know why that is. I just find that the patient rewards do not seem to move the needle, whereas when it's part of a workflow and work, they seem to work. I don't know why that is B2B versus B2C, but I will highlight, I get asked this question, we test it every so often, but again, I haven't seen kind of convincing evidence that it really moves the needle.
Thank you, Michael. Jay, let's go to you next quickly. We've got just a couple more minutes.
Well, this is a quick one. It's for everybody, but Dr. Furr, you kind of pushed me this direction. To what extent are you using e-consults to increase specialist access or to increase specialist communication? Because specialty access is a real issue nationally.
It is, and we're in a rural area, so it's even more so. So we're having some of our specialists particularly use it for their follow-up visits, for their post-op, or where they've already had their initial consultation with the patient in person and then do their follow-up visits. It's been particularly helpful for mental health, but even our GI guys and our cardiologists are using that to some extent. So it has been helpful. The rate limiting factor for some of our patients is still the technology. In our areas, a lot of them do not still have broadband. So that's why it's really important for us that we keep pushing for payment for audio-only telehealth, because there are just some patients that don't have the high-tech capabilities, but it has been a tremendous help for us.
And Jay, you're muted, but Jay wanted to hear from each of you about e-consults.
We also heavily use e-consults despite the number of specialists you saw there, partly for access, to solve access problems and partly for timing. So we use this a lot.
I can't say it because I don't participate in a specific practice, but I will say that the MSSP did start to reimburse for telehealth consults as an incentive for participation. I think that's a good step in the right direction.
Thank you.
We want to thank each of you for all of your expert presentations and the tremendous knowledge that you've brought to the table today. We've covered a lot of ground during this session, and you're welcome to stay and listen to as much of the rest of the meeting as you can. At this time, we have a short break until 10:50 Eastern. Please join us then for a listening session on developing a balanced portfolio of performance measures for total cost of care models. Thank you for joining.
Produced by the U.S. Department of Health and Human Services.